Good afternoon. I'm Isobel Mackenzie, Seniors Advocate for the province of British Columbia. First of all, I'd like to acknowledge that I am speaking to you today from the ancestral lands of the Lekwungen-speaking people of the Esquimalt and Songhees First Nations. As the Seniors Advocate, what I hear most from seniors is their desire to live at home in the neighborhood they know, surrounded by the people they love. And fortunately, in British Columbia, this will be the reality for the vast majority of us. Currently, only 13% of seniors aged 85 and older in BC live in long-term care. We are not just living longer, we are living more years in good health, and most of us are living in our own homes for the entirety of our lives. However, some of us will need help, possibly considerable help as we age, and with a growing seniors population, if we do not make changes to how we are doing things today, we are going to see increased pressure on our already burdened healthcare system. Key to managing the aging process to ensure we live in our own home with limited trips to the emergency department is access to the support and services we might need as we find some of our daily tasks more difficult to manage. Most often, we will get help from family and friends or one of the many government programs that are available to BC seniors. However, the key program that is aimed at keeping seniors out of hospital and reducing the need to move into long-term care is our provincial home support program. Home support provides assistance with basic care needs such as bathing, getting dressed, managing medications, help with toileting, and other personal care needs. The philosophy behind the program is that with just a little bit of help a day, a person can remain in their own home. This is what seniors want, and if managed correctly, it can prove a more cost-effective approach to supporting an aging population. The report I am issuing today is a systemic review of BC's home support program that looks at trends over the last 5 years and concludes that we need a fundamental restructuring of our home support program if we are going to meet the needs of a growing seniors population. This review has examined tens of thousands of clinical records and includes the feedback from over 6,000 current home support clients and their family members. I would like to thank the many people whose efforts made this report possible, the thousands of seniors and their family members who've taken time to provide their personal feedback, and as always, the dedicated team in the Office of the Seniors Advocate who worked tirelessly on these reports, particularly in the days leading up to their release. So just a recap. Home support's designed, as I said, to offer personal care, bathing, help with toileting, these what we call personal care services. The services are delivered by trained community health workers under the supervision of professional nurses. Currently, home support client profile, average age is 84, 64% are female, about half of them live alone, about a third of our clients are married, 14% require English translation, that trend is growing, 33% have a diagnosis of dementia, 4 out of 10 have fallen within the last 90 days, 4 out of 10 take 9 or more medications, over half are at high or very high risk for admission to long-term care, and 34%, a third, have a family caregiver who is in distress. When we asked current clients about the services they are receiving, the feedback was relatively high levels of satisfaction. Most people rate the service as very good or excellent, but the proportion that are prepared to rate it as excellent actually has dropped 30% since our last survey. It is comforting to note that the clients overwhelmingly felt the community health worker who provided their home support services treated both them and their family members with respect, and almost no one felt they were discriminated against because of race, nationality, gender, socioeconomic status, sexual orientation, or disability. However, there are some fault lines beginning to appear, and we need to pay attention to these. Less than half of clients feel that there's always enough time for their care staff to complete the work that is needed, and the lack of consistency in that care staff is challenging for many of our home support clients. Almost a third of clients experience financial hardship in paying the cost of their home support, and just over 30% of clients reported needing additional services such as housekeeping and meal preparation. And that's about what it was when we did the survey 5 years ago. Family members today are reporting that they're less likely to feel that home support's meeting their family members' needs than they were 5 years ago. And the need for more respite than we are currently providing is being felt by an increasing number of family members of our home support clients. When we look at what the data are telling us has been happening over the last 5 years, we can see why some home support may be working well for some, but it is perhaps leaving many behind in terms of supporting their actual care needs, the needs of their family members, and it is failing to keep many people out of long-term care for as long as possible. So as we can see here, if we look at funding levels over the last 5 years, home support funding in the last 5 years has increased by 42%. Interesting to note that in home and community care overall, the funding has increased by 50%, but we have spent approximately almost $700 million last year in providing our home support services. And we provided that, used that $700 million to provide about 9 million hours of home support to about 41,000 seniors. And again, if we look over the past 5 years, we can see that the number of clients receiving home support service has grown by 6%. And the number of service hours has grown by about 5%, and we do see a slight decrease in the average hours of care per client. Some might say it's about the same, but it's down by about 0.5%. Now, one of the measures we would use to say, are we keeping pace with demand, is to measure this growth in the past 5 years against the growth in the target population. And we do that by measuring a rate per thousand of the target population. So when a person needs home support isn't immediately when they turn 65. As I said, the average age is 84. The average age actually of someone in long-term care is about the same, it's about 85. So we looked at age cohorts 65, 75, 80, and 85 plus, and we looked at the population growth in those age cohorts and the clients, the home support clients in those age cohorts. And what we found was that regardless of which age cohort we used, there was a decrease. In other words, we're not keeping up the rate per thousand of population. So it goes from a decrease of 10% in the population 75 plus, so that's the beginning of the baby boomer wave. The oldest baby boomer is 76 this year. And then we see that it's decreased 5% in the rate per thousand of people 85 plus, and that really is our target population, the 80 plus and the 85 plus. So we're not really keeping pace in terms of the growth in the target population. So the next thing we looked at was the client complexity. How has the face of the home support client changed over the last 5 years? And so we use a bunch of different measures to say, are you more frail and complex today than you were 5 years ago? The 5 measures that we focused on here show an increase in complexity in 4 out of the 5 measures. The one measure not showing an increase, and arguably a very, very small decrease, is dementia. But interestingly enough, we see an increase in the moderate to severe cognitive impairment within that group. So if we look at MAPLE 4 and 5, which describes a person who is at risk or very high risk of placement in long-term care, we can see that that has risen slightly. Dementia, arguably the same or a little bit less. Aggressive behaviors are up a bit. ADL 3+ is a measure of a person's physical function, so we can see that there is an increase in people who are having challenges with their physical function. And CPS, or Cognitive Performance Scale, is a measure of their cognitive function, and we can see that there is an increase in the percentage of home support clients who have compromised cognitive function. So, you know, however you sort of look at this, you can see that the home support client that we are caring for today is frailer and more complex than the client we were caring for 5 years ago. Not dramatically so, but it's a fairly consistent and persistent pattern. And what is important to recognize is that despite this rise in acuity, only 30% of clients receive daily service, which translates into 6 out of 10 home support clients receiving less than an hour a day of home support, less than an hour a day. Compared to 5 years ago, we know that the percentage of daily visits is down slightly, and the percentage of those visits that are less than an hour is up slightly. And those are not the way you would see those two trend lines normally going. Now, the other thing we did was we matched the client complexity to the hours of care. So who's getting what in terms of care levels? So for this, we simply picked the measure of at risk or very high risk of admission to long-term care. That's just over half of our home support clients. And what is interesting here, first of all, you can see the comparison 5 years ago to today. 57% of our highest risk clients in our home support system are getting less than an hour of home support a day. And that is higher than it was 5 years ago. So 5 years ago, more people were getting an hour and fewer were getting half an hour. Now we see the reverse, and that is not a trend line that you want to see. And once you look at the higher care levels, 2 hours, 3 hours, 4 hours, you find relatively no change from 5 years ago, again, despite the fact that we've seen this increasing complexity in our care population. So the question then is, okay, where is the care coming from? You can't be living at home at high level or very high likelihood of admission to long-term care and be getting less than half an hour of home support a day. Well, that care is coming from families, from family caregivers. And what we looked at, so we looked at over the past 5 years, family caregivers are providing 11% more hours of care to their loved one than they were 5 years ago. And they are providing 5 hours of care for every 1 hour of care that is provided by the home support system. So not surprisingly, a number of them are in distress from this additional burden. And while the overall level of caregiver distress has not changed in the last 5 years, it was 34% 5 years ago and it's 34% today, when we look at the level of distress by how much home support they're getting, it looks a bit different. So what is very interesting here is to say the level of caregiver distress amongst clients who are receiving less than an hour a day is 57%. It was 55% 5 years ago, it's 57% today. And you can see that as you start to provide more care, the distress level goes down. So the people who are getting less than an hour a day have twice the level of distress from those who are getting an hour a day. The people who are getting 2 hours a day, again, have more than less than half the level of distress of the people getting an hour, and so on and so on. So there is a clear linkage here between you provide more care through home support, you will lower the distress level of the family caregivers. So one of the questions that we also have to ask ourselves is, okay, so we know that overall the program is providing fewer hours of care on average to proportionately fewer clients in our community, and those clients are more frail and complex than they were 5 years ago. That's the general picture that is emerging out of looking at the data of who is receiving home support. But the bigger question is who is not receiving home support services and why. So we know that the waiting times for long-term care have been increasing. Our ambulance service, emergency rooms, hospital beds, they're all feeling this increased pressure. And we know that in all those areas of our health system, seniors are having an impact, and home support is there to help relieve some of these pressures. So why are we seeing these pressures, and why are so many people not receiving home support? Well, first, the why. The biggest barrier to receiving home support in BC is how much we charge you for it. The majority of provinces in Canada do not charge for home support. And of the provinces that do charge, BC is the most expensive. I'm going to use the example of a single senior, who's earning about $29,000 a year from her various pensions. At $29,000, she's making too much to be receiving the GIS, the Federal Guaranteed Income Supplement. Yet her income is still very limited. If this woman was to receive just 1 hour of home support each day, 1 hour of home support each day, we would charge her $9,000 a year for her 1 hour daily visit of home support on her income of $29,000 a year. She simply cannot afford this. She's got to pay her rent, she's got food costs, she's got other health expenses, she's got to get medical supplies, she's got to figure out how to have a phone, how to have Wi-Fi in her home. She can't find that $9,000 a year for her daily home support. If her income was higher, we would charge more. The formula we use for what a person pays for their home support is based on their income. If she received the Guaranteed Income Supplement, the federal GIS, as 29% of our seniors do, we would waive the daily charge. This is again an indication of the relationship between using home support and paying for it are clearly linked. While only 29% of BC seniors receive the GIS, 65% of home support clients receive the GIS. And of the remaining 35%, almost all of them indicate their home support costs are a financial hardship. A person is 5 times more likely to use home support if they do not need to pay for it. So what are the people who cannot afford home support doing? Some of them are moving to long-term care. So we look at who is not receiving home support. We know that when we look at new admissions to long-term care, 61% had no home support in the 90 days prior to their admission to long-term care. So let's think about that for a minute. 6 out of 10 people admitted to long-term care went from effectively no care to total care in long-term care overnight. The reality is they didn't have no care, they had family members. And that is why the highest level of caregiver distress is found amongst those who are admitting their loved one to long-term care. Another measure we've looked at, and this is a Canadian Institute of Health Information, CIHI data that looks at all provinces across Canada. We look at the new admissions from a clinical profile, and CIHI says, okay, based on this clinical assessment and profile, you have low care needs that actually could be accommodated in the community. And when we look at that measure, British Columbia is 34% above the national average. So we have 34% more people in long-term care with low care needs that could be met in the community than the national average. But what is most significant is when we look at Alberta and Ontario, who are 2 provinces that do not charge for their home support, we have double. We have twice as many people with low care needs in long-term care in British Columbia as they do in Alberta and Ontario, where they do not charge for their home support service. So to put this in a stark perspective, when we look at the cost to the system, we are saying that we are not prepared to pay $14,000 a year to give this woman 1 hour of home support a day, but we are prepared to pay $60,000 a year to place her in long-term care. The total cost in long-term care is $84,000 a year, but the delta between the 60 and the 80 is what the client, there is a resident or a client copay in long-term care. So that's what it's costing us. $60,000 a year is the subsidy for long-term care. $14,000 would provide 1 hour of home support a day. $28,000 would provide 2 hours of home support a day. So we need to think about this sort of penny-wise, pound-foolish approach that we have to charging for our home support and making the economic incentive compelling for the individual to move into long-term care, but doing a great disservice to the cost overall to the system. So based on the finding of this review, I have made 5 recommendations to government on things they can do to improve the system. So first of all, eliminate the financial barrier for accessing home support. I spoke about this in our report we did, I think it was 4 years ago. I've spoken about it in our incomes report and identified it. We cannot disregard the overwhelming evidence that links home support utilization to whether or not a person has to pay for it, and the lack of home support linking to premature long-term care admissions. It is compelling. The second thing we need to do is increase respite care to families. We have, the system will collapse if these family caregivers tool down from exhaustion. For every hour of care we are providing, they are providing 5 hours of care. And we know that if we provide more care, their stress levels will be reduced. And we have to find a way to do that. Thirdly, we need to standardize and set targets for all aspects of home support delivery. Whatever it was, 10 years ago, people said, yeah, what are the hours of care we should provide in long-term care? And then we came up with the number. We identified a number, 3.36 hours. And then we started to measure it. And the first time we measured it, about, I can't recall, something like 90% of care homes weren't providing 3.36 hours of care. But we were starting to measure it. We'd identified it, we started to measure it. And over time, we now find ourselves with most, not all, but most care homes are delivering the targeted number of hours. We need to take that approach to home support. We need to say, what is the target of hours you should receive based on this assessment, and monitor how well we are doing against that, and also monitor in terms of the admissions to long-term care and set our targets. We need to modernize the care plans. So just like our survey 5 years ago, and the continued calls and letters to my office, and I'm sure to many others, are the frustrations that the current recipients of home support feel around a very restrictive care plan. So, the reality is there was a logic to time for task approach to assessing hours of care, but sort of lost in all of that was the reality of the nature of the client and of home support. If I'm going to be in this home for an hour or two, I should be looking at how can I meet the totality of the needs and not the prescriptive what is on the care plan. It could be on the care plan to go and give a bath or a shower that day, but you arrive and the client is just not feeling like they can have a bath that day. They may be under the weather, have a bout of flu. Instead of turning around and leaving, we need to have a system that gives the flexibility to the worker in that home to say, what else can I do when I'm here that would be helpful for you? Can I do some laundry? Can I do some cleaning up? We need to modernize those care plans. And part of the ability to attract and retain the workforce that we're going to need to provide a much expanded home support program is also going to link into the modernizing of those care plans. And we need to measure, monitor, and report on performance. So again, in our long-term care system, we have licensing, we have regulations under the Hospital Act or the Community Care Assisted Living Act. That is all missing from home support. But what is clear is that in the homes of seniors throughout this province, we are caring for people who are as frail and vulnerable and complex as people who are living in long-term care. And that's not a bad thing. That is what a lot of people want. But we need to approach the monitoring and reporting on performance in the same way we do for our more frail seniors population. And with that, I am happy to take any questions that people may have.
Thank you. A reminder to media on the line, please press *1 to enter the queue. You'll be limited to one question and one follow-up. We will go with the room. We're going to start with Richard Zussman, Global News.
Isobel, I'm trying to understand how we got to a point where, here where this became a cost that people paid for, where we don't see that in other jurisdictions. Like, is this something that's been built in for a long period of time? And how fundamental of a change would it be for the province to roll in these sort of supports into the overall healthcare network?
I've been around in home support for 30 years now, Richard, and there was a co-payment and it's exactly the same formula, actually, that we used 30 years ago to determine a client contribution to home support. So it appears that it has been a very long time a part of our home support system in British Columbia. The question of shifting to how could we move from that to offer it free of charge? Well, over half the provinces in Canada managed to do that. And two very large provinces, Alberta and Ontario, managed to do that. So clearly it can be achieved, and it can be achieved without collapsing the system. The systems in Ontario and Alberta haven't collapsed. So I think what I hope is that aside from the sort of it would be a nice thing to do, I think the evidence is fairly compelling that we are seeing premature admissions to long-term care, in part, not totally, but in part because of the cost barrier of our home support services. You simply can't pay it. Where's the money going to come? Where's $9,000 a year going to come from if your income is $29,000? That's 31% of your income, and you still have all the other costs to pay. So, we've got to recognize that, and the evidence, when you look at Alberta and Ontario, is also pretty compelling that we'll find some savings, not total savings, some savings by deferring those admissions to long-term care.
One of the phenomena that's unique here is in some cases people still have the asset of their home, which in British Columbia, yes, we've seen real estate in other provinces, but has gone up dramatically over a period of time. Is there any thought, is there an exclusion around that people may be on a low income like this, but living in a property that when they move or die, that there's huge value there? Does that factor in at all, do you believe, in the sort of consideration that, yes, it may seem that people on paper are financially not doing well, but have this large asset? And could that be potentially a sticking point here for government as they consider your recommendations?
I think that is a question that you would have to apply across a broader suite of services. So the first thing is, real estate prices are high in the GTA as well, right? So, Alberta, to be fair, is different, but in the GTA. It brings into focus another issue, which is all of our programs income test, none of them asset test, except for senior subsidized housing, where we do an asset test, and income assistance, where we do an asset test as well. So if you're moving into long-term care in British Columbia, we do take 80% of your income. We do not look at your assets. And more importantly, when you come into long-term care, we take 80% of your income, but only up to a certain point. So the cost of a year in a long-term care bed is, I think it's something in the neighborhood of about $84,000 on average, right? Well, we don't keep taking 80% of your income until it gets to $84,000. We stop. I think $3,600 right now is the new numbers have just come out. So $3,600 is the most you will pay for a bed in long-term care in British Columbia, and most people are in a publicly subsidized bed. And most publicly subsidized beds in BC are a single room with an ensuite bath. They look and feel just like the totally private ones, right? So if you're going to say on the one hand, we're going to look at your assets for home support, we're going to have to do that for long-term care as well. Or the economic imperative for the individual is still going to be there.
Next question, Dirk Meissner, Canadian Press.
Hi, Isabel. So of the people in the survey who reported excellent 5 years ago and now are saying it's not so excellent, what kind of services are they saying what has gone down from 5 years ago?
Well, and again, mostly they've shifted down from excellent to very good, right? So the majority of people are still expressing general satisfaction, general high satisfaction with their home support. The high satisfaction is what's decreased. So what you find if you look through it are things such as the percentage of time that the worker always arrived on time. That's down considerably. The number of people feeling that the workers rushed in providing all the services, that's increased. The feedback time and communication with the office is not as satisfactory as it's been. Now, over this 5-year period of time, we've had something called a COVID pandemic. It will have had an impact on that. And the degree to which that impact is felt in the survey responses, we can't really tease out. But where it's the same as it was 5 years ago is still this: we need additional services, right? We're not getting the housekeeping, we're not getting the meal preparation, the consistency of workers. We heard about that before, we continue to hear about that today. We did get a lot more comments. We had about the same response rate this time as we did last time, but we had a lot more actual comments this time than we did last time.
Okay. And my next question is, I think in the throne speech, the government didn't even mention seniors in the throne speech, and now on Tuesday, there's a budget coming. What would you like to see them do for seniors in the budget?
Well, that's a pretty long list, and they've got a lot of other people that want to see their name on that list as well. In terms of this particular program, we have got to eliminate this cost barrier. That is something we can do quickly and can have a very immediate impact. Fixing the system, so there's two issues. There's where is the system not meeting the needs of the people receiving the service, and then what about the people not receiving it? So we can fix the people not receiving it by removing a cost barrier, so we know that that's not the reason why. The fixing of the system of home support so that we get more care into the people with higher needs and we reduce the stress on their family caregivers, that cannot happen overnight. But it also isn't going to happen without a definite plan with some measurable milestones. First of all, we are going to need to increase the workforce. Now, interestingly enough, the percentage of community health workers went up by 25% over the last 5 years, although, as I say, the hours only went up by 5%. But we're going to need to do that and redesign the system, look at, putting some of these services we've pulled out 30 years ago and informally pulled out over the last 20 years. We're going to have to put those back in and tell community health workers, yes, you can clean the house. Yes, you can actually make the meal, not just heat up what's already been prepared. And that won't happen overnight, but you should be able to measure a discernible shift in the next 3 or 4 years, but we have to start the work now.
Next question, Cindy Harnett, Times columnist.
Given the importance of this, as you've laid out here, do you want the province to fund home support? And if so, why are you not calling for that today? What would be the approximate cost, do you know, of funding that? And, or maybe what would you suggest if you're not calling for that? What would an alternate payment model or sliding scale look like?
It's a good point. What I've called for is to eliminate the cost barrier. So is that free as we see in Alberta and Ontario, or is it a version of something like we see with Fair Pharmacare where it's a very lower percentage, 3 or 4% of your income? Or is it a version of the earned income cap that says we will cap, $300 a month is the most you will pay for your home support, and you don't even pay that much if you're at lower income, and a variation of that. I think that the measure would be that we would see a more equitable distribution within our client load. So it's very compelling that 65% of our home support clients have the GIS, when only 29% of seniors have the GIS, right? What you would like to see is that the population in home support more accurately reflects the total seniors population, and we're not seeing that now. So is that totally free, or is there a minor amount? I think I want to give the government the latitude to work on that a bit. But as I say, the majority of provinces don't charge for it. And so there's a compelling argument that that's where we'd start. In terms of what it would cost, the estimate of fees collected from those who are paying is about $31 million. I think that's what the ministry has told us was collected last year in the client copayment. So that obviously would be eliminated or significantly less. But of course, the bigger question is who's not receiving it now that will choose to receive it because it is no longer cost prohibitive for them to receive it. That's more difficult. You could argue that we would look at that group of people admitted to long-term care, that number, and target that as a group that we would most likely shift from long-term care into receiving some home support. We can also look at the other provinces that don't charge for it. And I think that is something that I would encourage the ministry to do, because I think it will relieve some anxiety. As I said, the world has not fallen apart in Alberta and Ontario where they do not charge for this. It doesn't solve every problem, but it does solve this issue of these people prematurely entering long-term care. We talk a lot about ALC in our hospitals. Well, we have some ALC in our long-term care as well.
So following on that, how much longer would you give the government to figure this out in terms of reducing or eliminating the cost of home support? And can you explain why would a senior go into long-term care when the cost based on, say, 3 or 4 hours might be relative, for home support or long-term care? Why would they go that option?
So I'll answer the first question, and then I think I understand the second question. So the first question is, they can do it immediately. This isn't a new issue, and it's not the first time I've raised it. And so my expectation will be over the next year that this issue will be addressed, meaningfully addressed. So either eliminated or meaningfully reduced. The second question, if I understand it, is why would I move into long-term care and pay my $3,600 a month versus stay at home? And okay, so the reality is most people, so if you're paying $3,600 a month, it's because you're at the income cap. So your income is about $64,000 a year. That's about 8% of people in long-term care. So what we find is most people in long-term care, their average contribution is significantly less. It's about $1,800 a month, and their incomes are considerably lower. So again, we find that the people with the resources, the people with the money, aren't in long-term care. They're at home because they can afford to bring the care in, just as you've identified. Who's in long-term care are people who can't afford that. So the average income of a person in long-term care is only about not much more than $29,000 a year. And the average contribution, I think, it changes every year, but it's about $1,800, $1,900 a month is what they're contributing.
We will now go to the phone lines. Moira Whiten, Gatayi.
Hi, thank you for taking my question. Isobel, I'm wondering what should be made of the increasing budget for home and community health services, but the static care hours, care hours remaining static or even decreasing on average per client. Where did that money, I know that's not specifically for only home support, but where did that money go, and what is there concerns of administrative bloat or money not going to providing that patient care?
I think one of the things we have to recognize is costs are rising everywhere. And so we can't equate an increase in funding levels with an increase in service levels. And that is clearly demonstrated here. So to be fair to government, they've put 42% more into home support over the last 5 years. It hasn't translated into a 42% increase in service levels. It's translated into a 5% increase in service levels. So where did some of the money would have gone to rising wages. So over the last 5 years, people have had some wage increases. Some of it will have gone to training. Some of it will have gone to some of the pandemic measures that we saw. So, we now, more people are being provided with paid sick leave, and more people are using that paid sick leave. It all costs money. And I think it's part of just a bigger picture that we, the public at large, have got to realize, and all governments at every level and every stripe are wrestling with, which is we have an aging population. They are going to require help. We have fewer people proportionately to provide that help. So when the pool of available labor shrinks and the demand for that labor increases, wages will rise. And so it's going to cost us more. It's going to cost us more in the future to deliver the same thing that we were delivering today. And we've got to understand that. And the lesson is don't necessarily equate an increase in funding to an increase in service. But what it also shows is the government is not saying we're not increasing. They did increase. Now, home support did not increase proportionately to the same degree as other areas. Home and community care overall increased 50%, and home support 42%. So the biggest piece of that is long-term care. And, we have to really think about that. Long-term care costs are going to rise. We have our average per diem today is going to look much different in 5 years because we need more people and we need to pay them more. And so everything is going to move in relativity to that. So unfortunately, people want to have these sort of, if we, we can do this and it's cost neutral, and no, it's going to cost more money, because what's the alternative? Like, we need to think about what is the alternative. We are paying people to take care of people. What is the alternative?
Follow-up, Moira?
Thank you. Yes. Again, on the staffing angle, when we look at the workforce, I know in the survey it mentioned that some seniors and their families noted that they got, multiple different care workers. It was hard to build a relationship sustainably when you were getting multiple people in a week. Would creating more full-time positions or salaried positions help these workers, or what other, structural staffing changes would support, just better continuity of care?
Okay, I think I've got the essence of the question there, Moira. I'm sorry you're breaking up a bit here to hear you, but I think it is really about the workforce, the community health workers. Would creating more full-time regular positions allow us to deal with some of these issues that clients are experiencing, such as I'm getting different workers all the time, et cetera? The short answer is, to some effect, yes, it would. So, the challenge in home support is currently about half the workforce is still casual in home support. And these are now all government employees, right? They're all employed by the health authority now. But there's still about half of them are casual. And the ones who are regular, in order to get a full-time job in home support at 37.5 or 40 hours a week, you generally have to work a split shift, because we've narrowed the scope of services we provide so much that it is basically morning care. And you can't give morning care at 2 p.m. What can you do at 2 p.m.? You can do housekeeping. Well, we took that out of the home support program. What can you do at 2 p.m.? We can be giving part of a 3 or 4 hour respite block of care. but we're not doing that very well or very much. We could be going in and we could be doing much more around rehabilitation. We could be taking people for walks. You get the idea. So we're going to have to change the scope of services, and we're going to have to modernize those care plans so that there is things for community health workers to do over a consecutive 8 or 9 hour period of the day. Because right now it's chopped up. We have a bunch of service we need in the morning. We need to get people up. We need to get them their medications. We need to get them going. Then the next big bulge we see is around the supper time when we're going in and we're giving supper. Correction, we're heating the supper up. We're giving dinner meds. And then again, what we call HS service or nighttime service when we're going back around 9 p.m. or so to put people to bed. And in between, when you look at what are the authorized services, people are going to be scratching their head going, well, yeah, what are we going to do at 1 o'clock, 2 o'clock, and 3 o'clock in the afternoon? There's nothing to do because we can't do all those things. So everything moves together. So that was a very long-winded answer to your question, Moira, but the short answer is yes.
We have no further questions, so that concludes today's event.